full professor at the Department of Endocrinology and the Department of Molecular Medicine at the Aarhus. I'm spelling it the right way, right? Aarhus, right?
Yes, yes.
And Aarhus University. He coordinates the clinical and research activities at the Center of Disorders of Sex Development at Aarhus University since 2016. His main research focuses on morbidity, mortality, genomics of Turner-Klinefelter and other disorders of sex development. He has contacts with several patient organizations such as the Turner Syndrome Association, the Klinefelter Syndrome Association, and Congenital Adrenal Hyperplasia Association in Denmark. And he's going to give us a talk about Turner Syndrome, fertility, and HRT. The floor is yours, Professor Klaus.
Thank you very much for the nice introduction and for the invitation to give this lecture. So I'm going to focus on fertility and hormone replacement therapy in Turner syndrome. And I'm going to my disclosures here for the recent work on the international guidelines on Turner syndrome. We got support from Novo Nordisk and Ascendis Pharma and to develop these new guidelines. And they were published in 2024. And I'm going to talk from them as a basis, but I'm also going to give you some new information on fertility and treatment with estrogen and progesterone and so on. So the scope of the guideline was to describe all temporal stages of life with Turner syndrome and all aspects of conditions seen in Turner syndrome. And that meant that we included pediatricians, adult endocrinologists, cardiologists, fertility specialists, and gynecologists, and so on, and in order to develop these guidelines. And you, of course, all know what Turner syndrome is, but we state very clearly that it is a condition that affects phenotypic females who have one intact X chromosome and complete or partial absence of the second sex chromosome. And that means that you can see a host of different karyotypes that all leads to the clinical syndrome of Turner syndrome. And you, of course, also know a lot about the typical features of Turner syndrome, and we have listed them here. The most typical features are, of course, short stature treated with growth hormone if you diagnose the patient early enough, and then hypogonadism, which is then treated with HRT. Infertility is present in most. Hypertension, hypothyroidism, middle ear infections, and hearing disability is some of the things that we also see. The prevalence is about 1 in 2,000, and the median age at diagnosis is 15 years, and this hasn't changed in recent years. So there are many organ systems that are affected by Turner syndrome, for example, body composition, neurocognition, cardiovasculature, fertility, the immune system, and the metabolism, and so on. And then there is this presence of hypergonadotropic hypergonadism, which leads to the need for hormone replacement therapy. And that is what we treat these patients with when we induce puberty and then onwards into adult life and further on. So how many do actually receive HRT? Well, these are some Danish data that I'm showing you, just emphasizing that although we think that most would receive HRT, there is actually a small percentage that, or not so small percentage, that do not receive HRT. And the reasons for this are not quite clear, but this is data based on about 1,000 patients with Turner syndrome. So we think that these data are sound. In order to lacking estrogen, as shown in this panel, you can see that females with Turner syndrome are also lacking testosterone. And we're not treating with testosterone these days, but maybe we should consider that, because we can see that testosterone in Turner syndrome women are more than 50% lower than compared with normal cycling women in the black here. That is from normal cycling women. What does estradiol do Well, previously we showed that estradiol reduces blood pressure, and in this study we followed 20 women that were randomized to either high dose or low dose estradiol for 5 years, and we did not see any difference. However, we did see that during that 5-year period, in these young women with Turner syndrome, there was a consistent rise in blood pressure through the time we studied these patients. And hypertension is really one of the things that we see very frequently in Turner syndrome. And this is also some Danish data just showing you that very many develop hypertension, and the relative risk for having hypertension both before the diagnosis of Turner syndrome and after the diagnosis is at least threefold increased. And in this French study of about 1,500 Turner syndrome women, you can see that already early in life, from 10 to 15 to 20 up to 30 years of age, there is a consistent rise in the number of females that have hypertension. We studied the effect of HRT on blood pressure, and this was a study where we studied about 33 women with Turner syndrome, adult women. And in this study, we show that without treatment, blood pressure is higher. It was not consistently statistically significant, but in some of the cases, for instance, diastolic day blood pressure measured with 24-hour blood pressure measurements, we could see that there was a decrease in blood pressure when giving HRT for 6 months. So HRT seems to modify blood pressure, at least in young women with Turner syndrome. And we therefore think that there is a window of opportunity for treating with HRT, at least when participants are below 40 years of age. There are many questions related to HRT. As you know, we have estradiol receptors in all organs in the body, and therefore it is likely that estrogen affects every organ system. And as you know, if you don't treat with estradiol, we will see early problems with bone mineralization and development of osteoporosis. We also know that if we don't give estrogen, the uterus will not grow, and many opt for fertility these days. So therefore, it's necessary to have a normal growth of the uterus. How about the cardiovascular status? As I showed you, there is a reduction in blood pressure when we give HRT. And what about the cognitive development? That we don't really have good data on that, but we do have on liver function, because many patients with Turner syndrome, as you know, have elevated liver parameters. And when we treat with estrogen, we actually see a fall or a normalization in these liver parameters. And we can also see that if we give more estrogen, there is a further reduction in liver function. So HRT seems to affect many organ systems, and that is one of the things that we need to be aware of. This is a registry study we did in Denmark, and here we looked at 329 females with 45X, and in those that were treated with estradiol, we saw reduced morbidity in a number of different conditions, for example, stroke and osteoporotic fractures. There was a tendency to reduction in morbidity for a number of other conditions. And in the lower panel here, you can see that when we looked at the treatment they were receiving, we also saw reductions in the number of patients receiving anti-diabetics, antihypertensives, and thyroid hormone replacement therapy. So apparently, estradiol affects a number of different organ systems. In the guideline, we also talk about puberty and what to do there. And as a new thing, we have introduced measurement of AMH, and that is because AMH is probably the best marker of ovarian follicle development we have currently. And that gives you a good handle on whether there are any fertility prospects for this for your patient. We also recommend initiation of puberty at around the age of 11 to 12 years. And then we recommend adding cyclic progesterone once breakthrough bleedings occur. And then we recommend continuing cyclic estrogen and progesterone treatment until the usual age of menopause. And we recommend an individualized replacement strategy. Is there any news about progesterone treatment? Well, we recommend using micronized progesterone or dihydrogesterone as first-line products. However, the database for this is really not very strong. The doses of progesterone should be proportionate to the dose of estrogen, meaning that if you're giving a higher dose of estrogen, you should also be giving more progesterone. Studies of adherence and acceptability of different approaches and regimens are needed in view of reports of poor concordance with HRT. And then we also recommend the use of intrauterine devices with levonorgestrel as a very good means of treatment, and it gives you endometrial protection, and it's also very good if you don't want periods. So the effects of HRT is really on a lot of organ systems. We don't know exactly what the effects are on, for example, the central nervous system and on the autoimmune system and the different endocrine systems, but we do know that we see a reduced risk of hypertension, stroke, and atherosclerosis, an improved lipid profile, and normalization of liver enzymes, and also on the visceral fat and improved physical fitness, we see effects. And then, of course, for the sex organs, we also see we can normalize the uterine size, and on the bones, we see that we can normalize bone metabolism. Concerning cancer risk, there doesn't seem to be an increased risk of cancer and also not of breast cancer, which is interesting because that is something that you see in normal women. But in Turner syndrome, the risk of breast cancer is very low. And that is from different studies from different countries showing a very reduced risk of breast cancer in Turner syndrome. So this is a case, a woman that I've known for many years. She's now 56-year-old. She is 45X. She was diagnosed at the age of 10 years. She developed hypothyroidism at the age of 18. She was treated with growth hormone at the age from 10 to 14 years. She never had menarche, and she started HRT at the age of 14 years. At the age of 40 years, she would like to become pregnant, and as you can see here, she got ovarian donation, and she became pregnant and went through an uneventful pregnancy and delivered this baby, as you can see here. There was no problems with the heart during that time, and she was very healthy afterwards. And she is a preschool leader and is married to her husband. However, when I saw her recently, she had developed different complications seen in Turner syndrome. Initially, she was thought to have psoriasis. However, it was shown to be pityriasis rubra pilaris and treated with methotrexate. She was hospitalized twice recently with severe exfoliative dermatitis following antibiotics and statins that she didn't tolerate. She developed type 2 diabetes, which is very frequent in Turner syndrome, for a very modest BMI of 25.2. And then she also developed heart problems with angina pectoris, and she was shown to have a problem with the one coronary artery, but it was not possible to place a stent. She also developed hypertension and hearing loss, and now have hearing aids. And all this came during her adult life. And she also had allergy towards different medications, as you can see here. And she is now on this current medication after being really healthy for many years during adult life, but now she is receiving multiple medications, as you can see here. And what does karyotype phenotype associations tell us? Well, there are actually new studies, very large new studies, showing us that there seems to be an effect of the different karyotypes on the frequency of, for example, hearing loss, hypertension, the occurrence of bicuspid aortic valves and aortic size index, perhaps also of obesity and autoimmune disorders, and the development of primary amenorrhea. So knowing the karyotype is relevant because it may tell you something about the risk for development of different complications that we typically see during adult life. This is the French study that I showed you a little bit of data from before concerning hypertension. This is a study of about 1,500 Turner women. They were rather young, from 10 to 30 years, as you can see here. But please note the occurrence of different complications that happens really early on in life. You can see that obesity happens really early on in France. About 50% are obese by the age of 25. Hearing loss, about 40% will have hearing loss by the age of 30. Abnormal glucose metabolism, dyslipidemia, hypertension, and liver dysfunction is also very frequent in Turner syndrome. Celiac disease is also very frequent. So it tells us that we need to be vigilant of these conditions and teach our patients already during pediatric life a healthy lifestyle to avoid some of these complications. And that also leads us to some of the health surveillance management guidelines that we present in the new guidelines. We recommend screening for celiac disease with long intervals. We suggest measurements of complete blood count because anemia is also more frequent. And we recommend that Turner syndrome women and females are seen in a center where they know about all these different morbidities that can happen in Turner syndrome. And we also suggest that the Turner syndrome care team provide resources for additional education of patients, self-advocacy, and so on. And because today in my clinic, many opt for oocyte donation, the heart during pregnancy is also something that we are increasingly aware of. And aortic dilatation, as you know, is something that can be seen as a risk factor for dissection. And we therefore recommend individualized peripartum cardiovascular care, and that you examine your patient before any pregnancy in order to make sure that they don't have discrete malformations in their heart or other conditions that need a cardiologist with expertise in this area. We recommend tight blood pressure control and antihypertensive therapies and low-dose aspirin for the prevention of preeclampsia and hypertensive disorders during pregnancy. And we recommend that the mode of infant delivery should be based on the safest method to prevent aortic and obstetric complications. So, knowing that congenital malformations of the heart are very frequent, and knowing from different international studies that what kills Turner syndrome patients is a lot of different conditions, but about 50% of the excess mortality is due to heart-related causes. Knowing that it is really important to stress that in order to avoid this morbidity and increased mortality, you should involve a cardiologist in the care of Turner syndrome females. So the contemporary care of cardiovascular issues shows us that the about 50% of the excess mortality in Turner syndrome is due to congenital and acquired cardiovascular conditions. Most of these conditions should be readily diagnosed with the current diagnostic approach, and much cardiovascular morbidity can be prevented today with a proactive approach. And therefore, cardiovascular morbidity and mortality should be seen as avoidable to a large extent. And then coming to fertility, which is a primary lifelong challenge. it is in adult women with Turner syndrome seen as the most important problem related to Turner syndrome, ahead of short stature, lack of sexual development during adolescence, and fear and uncertainty regarding the long-term effects of GH and HRT. And it affects the majority of women, although some have spontaneous pubertal development and spontaneous menarche. Usually people stop menstruating early on in life. So therefore, again, we recommend AMH measurements and, if possible, controlled ovarian stimulation, and sometimes oocyte cryopreservation if you can do that. And then we recommend that ovarian tissue cryopreservation currently only should be offered in the context of an institutional ethics board approved research study or with clinical ethics board approval. Currently, there are 2 international trials ongoing using cryopreservation, one in the Netherlands, and we are performing another study in Denmark, a national study in Denmark, where we offer all females with Turner syndrome from the age of 2 to 18 years to have the one ovary cryopreserved for future fertility. Concerning neurocognition, we also emphasize that neurocognition is affected in many with Turner syndrome, and therefore we recommend that neuropsychological evaluations and behavioral, social, and emotional screenings should be used when you have a Turner syndrome patient. And we recommend that evidence-based interventions for cognitive or psychosocial problems in the general population be adapted to meet the needs for females with Turner syndrome. And we also recommend that Turner syndrome females receive counseling regarding sexual health. And then the clinic with Turner syndrome. This is our clinic in Denmark, where we have the Turner syndrome patient in the middle here. And then we have primary care. And then we have the hospital, where we have both the pediatric department and the adult endocrine department. However, we work together with a lot of different specialists on a need to treat basis. So the cardiologist, the gynecologist, the fertility specialist, the gastroenterologist, and so on a need to treat basis. We monitor our patients every year, and then we treat them individualized, but as optimal as we can. And then we, of course, in our institution also do a lot of research, but we think that this is a good way to deal with Turner syndrome in your clinics, because it means that I have seen more than 400 women with Turner syndrome, and that gives me a very good basis for answering most questions, at least. So the genetics of Turner syndrome, of course, as alluded to already, most are 45Xs. Mosaicism is frequent, and there are phenotypic differences, as I showed you before, between the 45X and all the other karyotypes. And new studies have shown that there are also epigenetic changes with hypomethylation of the DNA in both blood, muscle, and fat, and likely also in other organs. We also know that there are RNA transcriptomic changes in blood, muscle, and fat, and we suspect that this is also present in other organs. And we know that the autoimmune predilection is very high, with very many different autoimmune diseases seen in Turner syndrome. And then we also know that there is a frequent occurrence of the metabolic syndrome and type 2 diabetes. The risk of type 2 diabetes is probably increased with up to 4-fold increase. And recent studies have shown in Turner syndrome, but also in Klinefelter syndrome, which seems to present as a mirror image of what is happening in Turner syndrome. We and others have shown that a lot of different genes seems to be involved in different parts of the phenotype that we see in these two syndromes. For example, we have recently published data to show that the gene TBL1X, which is an X-linked gene, seems to be associated with neutrophil-driven inflammatory stress in Turner syndrome. And we already know that the SHOX gene is associated with height, increasing height in Klinefelter syndrome and decreasing height in Turner syndrome when you only have one SHOX gene. And then there are also data to suggest that the tissue inhibitor of metalloproteinases 1 and 3 seems to be involved in the risk of developing bicuspid aortic valves and perhaps also aortopathy. And you can see that there are other genes here that seems to be involved in parts of the phenotypic characteristics that we see in Turner syndrome. And recently, we have published data to show that the methylation profile seems to be increased or changed in Turner syndrome, so that there seems to be what we can call epigenetic early aging in Turner syndrome, perhaps explaining some of the increased mortality that we see in Turner syndrome. So in other words, work in the genomic area is moving forward, and we may end up being able to explain most of the phenotypic traits that we see in Turner syndrome. So what does all this mean? Well, it means that the genetics or the genomics of Turner syndrome, but also Klinefelter syndrome, is becoming untangled in present years. And subtle changes are present at many sites in the genome with discrete hypo or hyper DNA methylation that seems to affect gene expression and then perhaps phenotypic characteristics. And subtle changes in RNA expression are also present, likely leading to unbalanced expression. And changes seems to be tissue specific, and that means that we probably need to examine all relevant tissues in Turner syndrome. For example, if we talk about the metabolic changes, we need to be looking at the muscles and the fat, and we have been taking fat and muscle biopsies from adult women with Turner syndrome and examining these. Then changes also seems to be temporal, meaning that fetal life will likely show interesting results, and then as you age, there will be changes in the genetics of these individuals. And it seems that every trait in Turner syndrome has its own explanation. And therefore, I can also, for now, state that we don't understand everything concerning Turner syndrome yet. So with this, I hope that I have given you a brief overview of the intricacies of fertility and hormone replacement therapy and the effects of this in Turner syndrome. And these are some of my collaborators and a picture of my group here in Aarhus. And this is our funders that help us do the research that we are currently doing. With this, I will be ready to take questions if you have.
Thank you very much, Professor Klaus, for this very comprehensive talk. And it really was very informative. And I'd like to thank you myself. I really enjoyed the talk myself. Let me ask you a couple of questions,
Yes.
if it's no problem with you.
Yeah.
So, how do you tailor HRT regimens for patients with mosaicism or partial X deletions? Is it the same HRT for all Turner syndrome, or does it differ with mosaicism or partial X deletions?
Well, we basically use the same approach to all patients with Turner syndrome. However, currently we have what's available in my institution is both oral estrogen and progesterone, but also transdermal estrogen. And
Yeah.
currently we don't know what is the better. So for now, we leave it for the patients to try either the oral and the transdermal and then choose for themselves. In my country, these treatments cost about the same. So the patients can try either or the oral first and then the transdermal application of estrogen, and then decides for themselves which is the best for them. And but we use FSH and LH. We would like to see a normalization of LH and FSH and to see a sizable increase in the level of estrogen.
Mhm. In Egypt, we have only the femostone, which is
Yes.
IPSA. Abbott, sorry, which is Abbott, and
Yes.
it's either 1 and 10 and 2 in 10. One is the estrogen concentration, it's estradiol hemihydrate. And of course, we have the dydrogesterone for the progesterone. But I think this is not suitable for initiation of
Nope.
puberty.
Nope.
You have
You're
to
right.
give low doses of estrogen, right?
Yes, we start with low doses of estrogen, and then we gradually increase the doses over a 2 to 2.5 year long period before we go on to adult treatment. So you're right. During puberty induction, you should gradually increase the dose.
Okay. My second and last question, how do you counsel the families of the children with Turner syndrome about the fertility? How do you say to them to break the news or because
Yeah.
of course they are very concerned about fertility issues with
Yes.
other things, of course.
Yes. So the fertility issue is in my view one of the most important issues because it's devastating to be told that you will not be able to have kids in under normal conditions. But for quite some years now, we have had the possibility of offering oocyte donation, and in our hands, we have now become so experienced that we can treat most women without any problems during an oocyte donation pregnancy. And now we have this scientific trial running where we also offer oocyte cryopreservation during childhood. And this is, of course, new, and this is not a standard treatment, and this is not something we offer to everybody. So they have to be part of this clinical trial if they want this therapy. And what we do is that we take the one ovary out and then we cryopreserve it for later use once they have become adults. And then we re-implant parts of this ovary that we have removed in order to see whether we can generate a pregnancy with her own oocytes, so to speak.
And have this been done
Not yet,
so
because
far? Mhm.
no, because the trial has just started. So this is something we're doing in young females now. So they have to become adults. So we don't know the result, and
Yeah.
maybe this will not be feasible for the most patients. But we're trying to figure out who can we use, who can we offer this type of treatment to.
Okay. Thank you, Professor Klaus, for this talk and conversation and the answering of the questions, of course. And I'd like to leave the floor for Dr. Sameh if he'd like to add anything or just to thank Dr. Klaus.
Thank you very much, Dr. Klaus. Thank you very much for joining us for the second year. And thank you very much, my dear friend, Dr. Hassan. Thank you very much indeed. Thanks a
Thank
lot.
you. Thank you.
Thank you.
Bye-bye.
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 Angela?
Good evening, everyone. I'm Yasmin Abdelmegid. I'm a lecturer of pediatric endocrinology, Alexandria University, Egypt. I'm really glad to introduce to you Dr. Angela Lucas-Harrod. She's actually a senior clinical lecturer at the University of Glasgow and pediatric endocrinology consultant at the Royal Hospital for Children in Glasgow, where I've been lucky to work with her and actually all the Glasgow team in my SP clinical fellowship since 3 years under supervision of Professor Faisal Ahmed. Her research interests include DSD, differences in sex development, early onset hypogonadism, and early vascular aging. Her PhD was entitled Androgen Signaling and Vascular Phenotype in Boys with Hypospadias. She continued publishing various publications in internationally peer-reviewed journals, and she has been awarded many prestigious prizes, including the SP Young Investigator Award in 2022. Not only this, she is on the project management and teaching and learning committees for the international registries for conditions affecting sex development and maturation, and the SBD-SD working group. She will present to us long-term outcomes for people with differences of sex development, and I'm sure it will be an amazing lecture. Angela, the floor is yours.
Oh, thank you very much, and thank you for the kind introduction.